I'm pretty excited to see even this many people here at 7:30 to talk about value-based reimbursement because, you know, it's value-based reimbursement. Anybody here from north of the Mason-Dixon line? I know we have at least one north of the Mason-Dixon line. And if you, I know you're here and you brought the cold weather with you, but we'll let you stay. It's okay. It's okay. The point today is really to go through these models because there's a lot of new reimbursement opportunities out there. A lot of the providers I talk to kind of put this, you know, they just turn on the deer in the headlights look because they really don't want to think about some of these models and but they do bring a lot of opportunities. So the goal today is to hit these at a high level, but enough so that you understand them and can maybe look at them as an opportunity and at least assess whether or not it makes sense for you. This is also very informal, so if you do have questions, please stop me. I know we said we'd ask questions after, but if we can be interactive, it becomes a little more valuable to the people who are here. So why are we even talking about this? Well, there's a million reasons. So the national healthcare expenditures are going to increase to $5.7 trillion by 2026. That's growing at a rate of 5.5% per CMS. So that's going to mean 19.7% of our nation's economy. This one's kind of scary, especially if you live in Alabama or the South, because we're at the bottom of this list typically. Hospitals that keep operating business as usual will have a negative 15.8% margin by 2021. In case you haven't noticed, we're about to be 2020, so that's a little concerning. And I just went to the Alabama Summit, Healthcare Summit, and these numbers are pretty much spot on, with Alabama and a lot of the states in the South being at the higher end of the negative, lower end of overall reimbursement. I'm going to skip to what Ed Simcox said. Ed Simcox is the CTO, Chief Technology Officer of Health and Human Services. I had the privilege of having breakfast with him at a meeting last year, and you know there was a lot of speakers at that conference who talked about fee-for-service and changes in the system, and the CTO of HHS said, I don't care what anyone says, CMS is not making any more significant investments in the fee-for-service infrastructure. What that means is the infrastructure we have now to pay claims the way we do is all we're going to get. They're not going to make any more changes to that. So what they're looking for is the next way that reimbursement is going to be processed. Blue Cross Blue Shield of California gained $325 million in savings from 2010 to 2015. And percent of healthcare payments tied to value-based reached 34% in 2017. But the kicker is that's a 23% increase from 2015. So, you know, essentially we're spending more than we can afford. If hospitals don't change, they might have to close. And fee-for-service infrastructure isn't getting any better. So if there's proven savings, everyone gets on the bandwagon. So by show of hands, who's participating in MIPS? All right, keep your hands up. What about any incentive programs? Blue Cross, Cigna, anything like that? All right. Bonuses, patient-centered medical home, clinically integrated network. I'm losing people towards the end because these are the, but if you're doing all of this, you're already on the plane. And I talk about the plane because it does feel like we're building a plane in the air. It feels like we're making these rules up as we go along, and there's no real roadmap. I'm on the processing side, so I work with both the payers and the providers, and even the payers don't have a roadmap. So we really are building this plane in the air. There are some general rules for each of these models, which we'll go over today, but I want you to remember that there's no real, outside of what CMS puts down as rules, there are a lot of commercial models out there that are really making this up as they go along. So we're really talking, people talk a lot about value-based care, and I like to make a clarification about that because value-based care is what we talk about. We talk about quality. It's the nicer thing to say. It's what we talk about when we think about our patients. But the reality is this is all about value-based reimbursement. Because if we had lots and lots of money, nobody would have changed anything. But Medicare's running out of money, and so clearly there has to be a better way for us to do this. So value-based healthcare is a health delivery model in which providers, including hospitals and physicians, are paid based on patient health outcomes. And outcomes to me is Did the patient do well or do better than they did before? But it is important to note that outcomes in this world also includes cost. So cost is a big proponent, and if you look at all these models, as we move away from quality, which is the nice thing to talk about, cost is really what the focus is going to be on. And that's where the benefits are going to come from if you can manage the cost. Most of our models include a shared savings component, meaning if you can help them save money, they'll share that money with you. Likewise, if you don't save any money, they're going to want some money back from you. And incentives are based on savings compared to a benchmark. You'll hear me talk about a benchmark a lot, but a benchmark is essentially just a budget. So they establish a budget and say, hey, this is how much it should cost to do this kind of service for this kind of patient. And if it costs you less, meaning you file claims equal less than the amount of money that they think it should cost them, then that's the savings. And that's what they're looking for. So what actually creates value? And I get this question a lot because it's value is very subjective. Everybody has their own definition of what value means. But essentially, when we're talking about reimbursement, value is equal to quality, which is the value of the outcome, divided by cost. So if you put it down into a math equation, that's what it would be. But the translation is, if the cost of a doctor visit and prescription is $150, which is about right, the cost being the cost to the payer, the cost to Medicare, the cost to Blue Cross. The value of the outcome is that that person didn't have to go to the ER, and that would have been $2,500 they would have had to pay. Then $2,500 divided by $150 means that they saved $16.60 for every dollar that they spent, and that's what's seen as value by the payer. That is what's driving this. So then the big question comes, that $15 that's left over that we just saved, who gets to keep that? That's what all of these models are talking about, is who gets to keep that $15 because a doctor or a provider kept that patient out of the ER and provided value. You'll see me use air quotes of value because it's an elusive kind of term. Typically in Alabama, we see ACOs run by hospitals or payers. We're seeing that actually in most states where hospitals or payers kind of started ACOs. ACOs are accountable care organizations. And essentially, if you think about it as a population of people, population is assigned to providers, and providers are told, hey, it should cost you about this much money to take care of these patients. And if you take care of them for less than the money we think it should be, we'll share that money with you. So the same concept we've been talking about, but typically those were showing up run by hospitals, run by payers, not run by providers. New rules this year have changed that, and the conditions are very favorable for physician practices to actually run their own ACOs, to where there's no longer payers involved and no longer hospitals involved. There are several that CMS puts out. The Pathways to Success is the typical Medicare shared savings program. It's one that most people participate with if they're in the Medicare ACOs. There's also other ones, Next Gen ACOs. Comprehensive end-stage renal disease has its own ACO managing that particular condition only and all the associated comorbidities with that condition. And then all payer ACO models where Medicare even lets you pull in results and patients from other payers. So they're even looking at models like that. And then commercial ACOs, which would be like Blue Cross or Cigna. All right, so CMS's Pathways to Success is the most common. It is our, you'll see MSSP a lot, Medicare Shared Savings Plan. It is the one that is now very favorable for providers. You have to have 5,000 attributed Medicare lives to be able to participate in this. And it doesn't have to just be you. It can be you and another practice. It can be 5 practices. Alabama just started its own ACO called the Alabama ACO, and it has 16 practices. But at the same time, we have smaller ones that are 1 or 2 that have come together to get their 5,000 minimum. The term is for 3 years. It does expand telehealth services, which is something we don't see a lot of here, but we may see in other states. And what's interesting, it also improved beneficiary engagement, which means the ACO can actually offer incentive payments to the beneficiaries for taking steps to achieve good health. You know how you have seen, hey, if you come get your flu shot, you can get $10 gift card if you come and do this. Payers are actually offering gift cards to patients to come in and get their get their mammogram done, close certain gaps because of the benefit of to them, it also saves money. Your budget may be reset at the start of a new agreement period, and you can start with no risk in these models. You can say, I'm just gonna go in for the upside. If I lose money, then I'm not at risk at all. And that's where most people start. So this is a picture of what this looks like because I'm a visual person and it makes sense to me. So the way they get your budget, that benchmark, is essentially they look at what you charged Medicare for those patients for the last 3 years. And that would be your benchmark year 1, year 2, and year 3. And they bring those together to get a composite baseline, your composite budget. What made it favorable to doctors now with the new rules is you see this trend at the top? That's your neighbors. That's the other people in your region that actually make your composite budget higher. If your costs are already at or below the average in your area, then your budget's going to be higher than what you're already charging. You're already saving money, didn't even know it. What they do then is they say, okay, there's a minimum savings rate. From this budget, if you can save at least this amount of money, then everything above your budget, we're going to split with you. You're going to get to keep some of that. So in this model, here's the actual performance in that first year. Here's the savings. And that savings then gets split between the ACO entity and Medicare. And depending on the model you're in, yes?
The cost, is that cost per person or is it cost of the
Cost for your entire population of attributed beneficiaries. Remember, it had to be at least 5,000. So it would be your population of all of those patients. And the patients could change, but it's essentially your population of patients. And it's based on total cost per beneficiary, per capita, and then Medicare spending per beneficiary. There's two things that go into how they assess that budget. And then they also adjust it based on risk factors. So if your diagnosis show your patients are sicker, then it actually makes your budget higher. So diagnosis is important. Does that answer your question?
I think so. It's on a per capita basis. It's not on a practice basis.
No, it's not on a practice basis. It's going to be based on that population and on the patient cost. So it's MSPB, Medicare spending per MSPB, Medicare spending per beneficiary. It's early, and total per capita spending. So, yeah. So we already talked about this. There's your MSR line, and then your savings is what you get to split. If you're on a risk side, there's the same thing. There's a minimum loss rate. So just like you have to save at least this much to be eligible to get all that money or your portion of the money, if you're on a risk, you have to lose a certain amount before you're actually responsible for paying that back. So the minimal loss rate and a minimal savings rate. Now, I'm not going to go through all this, but these are the different levels of the pathway to success options. I'm only going to look at level C just to illustrate this because, again, I'm a visual person. If you kind of see it, it makes a little more sense. So essentially with level C, it is a risk. If once you hit your minimum savings rate from the first dollar, you get to keep, the ACO gets to keep 50% of all that money. Okay, so the ACO entity. If you were, in this case, there's a loss risk. If you go above your minimum loss rate, then you will actually be responsible for 30%. Not you individually, but the ACO would be responsible. So already it's leaning towards the favor of the provider. But if you think about when I went back and showed you this is a good opportunity if you're already spending less than everybody else. So that's what you're looking for. So that loss is minimal to nothing before you even start to play this game. All right, so if you look at this as money, here's an example. I don't know how many anybody real financially savvy. In this example, the benchmark is $5,000. So for this patient base, we need to spend no more than, $5 million. We actually only spent $4 million to take care of these patients, so we ended up with $1 million savings, which gives us $1 million to the ACO, I'm sorry, $500,000 to the ACO, and $500,000 goes to the Medicare. In that $500,000, there's a split between the ACO entity, typically, and the members, meaning the doctors, meaning the practices. That's all contractually done. In this example, the ACO entity, which is usually who provides the software, who gives you data, who's managing the process, gets 40%, and the rest goes to the providers. So if you turn it into money, the $500,000 gets split $200,000 to the administrator, $300,000 to the practices, and if there's 10 entities in the practice, that means every practice would get $30,000. That's it, simple math. If you were looking at a loss, the opposite, then at the 30%, you'd end up with $300,000 in losses. $120,000 would be the responsibility of the administrator, and $180,000 would be the responsibility of the ACO, meaning that each practice would be on the hook for $18,000 if they did the risk. This is like Vegas. The more you risk, the more you get a reward. So in those early models, you notice there's no risk. But you also notice you're only going to get 40% instead of 50%. Highest risk models, you get 75%. So the more you risk, the more reward you get. All right, any questions about that? This is a really good opportunity for primary care, especially if you're already efficient, especially if you look at your MIPS scores and your cost scores are great, you already know you are better than average, then your budget is probably going to be way higher than what you're actually spending already. Those are the no-brainer kind of decisions. But it takes somebody to actually assess that in your practice to say, does this make sense for me? Specialists need to be aware of who of their referral sources are participating in this. Because if they are being held accountable for all the costs associated for that group of patients, and you as a specialist are spending more than other specialists, then your referrals may stop sending those patients to you. And any primary care doctor who's participating in this cannot participate without a lot of data. I'm going to show you some data examples later, but that data tells them exactly how much each of those specialists is spending. Will actually tell them as it compares to other specialists in the same area. And I'll show you some reports like that. All right, any questions about those before we move on to bundle payments? All right, bundled payments is something we hadn't seen a lot of, but then out of nowhere they popped up, primarily with specialists. They are, typically it's just exactly what it sounds like. Single payment, it goes to one entity, and that entity disperses it out to everybody in the bundle. It's based on an episode. So instead of taking care of a whole population, you're looking at a single episode for a single patient and the savings for what you get for doing that particular procedure or that care. Like I said, it's mostly specialist, and it can be prospective or retrospective, meaning in a prospective, the claims are filed and a flat amount is paid, and that's it. You know, you send in a claim, all the services are included, you get a flat amount, end of story. No follow-up, you really don't even need a claims department other than somebody just send a claim. Retrospective is you file all those claims, they get paid at a period after the episode is over, after the bundle episode is over, they go back and compare it to budget, and then they see if there's a savings or a loss. If there's a savings, they give you more money. If there's a loss, they want some money back. One thing I may have failed to mention, and I try to make sure I keep mentioning, is in all these models, you're still filing claims. So this is not in lieu of your payment. This is on top of your payment. So you're already going to get paid for the claims and the services you provide in the traditional fee-for-service way. This is, think of it like a bonus, like a side benefit or incentive for the work that you do and the quality and efficiency in your practice. All right, so there are three real players in a bundled payment. I like to give them these fancy names, and it kind of bothers me because I'm like, why don't we just call them things that we all understand? The first one's an episode initiator. This is really just the hospital or the guy who starts the procedure, starts the service, starts the bundle. It's the guy who triggers the bundle. So if it's a hospital, it'll be the first day of that stay. If it's a doctor, it'll be the day they do the procedure. The convener is an interesting person in this whole process. Conveners don't have to be providers. They are essentially sort of this umbrella entity that does all the paperwork, they put all the data together, they manage everything, they may provide care services and navigation services to the patient. They financially bear risk in this model, but also get reward because they're providing that service to the providers to kind of manage the whole bundle payment. You don't have to have a convener, but in most cases, there is a convener there. Then there's participating practitioners, and those are really just people who are in your bundle that you are providing services with or have contracted with, but they don't get anything other than their portion of the payment. They're not at risk, and they're not at risk or getting any reward from the bundle. So if you look at this in relationships, all of this is a contractual relationship. There's a facility and the provider. They initiate all the services that are in a bundle. And then you have all these other participating practitioners like diagnostic imaging, labs, DME, rehab, post-acute, and other providers. All they are is people that hopefully have good, low cost, high quality that you can pull into being in your bundle and send those patients to save money. The convener is managing all these people by contract. BPCI is the main bundle payment program we see now. It is the one that's put out by Medicare. It is Bundled Payments for Care Improvement - Advanced. That's the name they gave it. So CMS program, the bundles are only available for the for Medicare patients. There's only 3 clinical episodes that are outpatient, but 29 that are inpatient. So the episodes that are outpatient are identified and triggered when that CPT code is filed, and in the hospital, it's when that DRG claim is filed. That initiates that bundle. I'm not going to go through all these, but these are the basic list of your inpatient bundles and your outpatient bundles. The ones that we see the most are going to be major joint replacement, lower extremity, hips and knees. We're seeing a lot of spinal fusion. It's somewhere up here, and there's your other spinal fusion, cervical and non-cervical. Those are the bundles that I've worked with the closest. And those are the things that tend to have the largest amount of savings available at the moment, which is why you're seeing so much movement on them, because there's a lot of variability for those procedures. Right now in Birmingham, Alabama, an orthopedist has a budget, and it's going to be a little different for each, but it's approximately $24,000 to $25,000 for every time they do one of these under this program. That payment is going to change wherever you go in your region and the kind of service you do. But every year you get that budget, and so that is your benchmark. So what goes in a bundle? A bundle lasts 90 days in this program, and to be short answer is everything. Everything goes in that bundle, even things that are not related to the service you provided. So this is the rub. This is where it's really Vegas here, because it's a gamble. All of these things are included, all physician services, not just the physicians who are part of this program. This is the CMS group program, remember? So hospital readmissions, SNF services. So somebody's got to manage these patients, get them out of some of these post-acute care settings where they're spending a lot of money if they don't need to be there. Drugs, hospice services. There are very few exclusions, and those are really, there are certain cancer diagnoses that are excluded, and transplant. Off the top of my head, those are the only 2. But everything else is included in the bundle. I had a doctor who was ahead with 9 episodes of hip and knee replacement. $50,000 ahead. He was ready. He was so excited. He was going to get his check. He had one patient that ended up getting re-upped for skilled nursing. Instead of going into just assisted living, she stayed in the skilled nursing part of the facility for an extra 3 weeks and ate up all $54,000 of his savings. He was very upset, and he said, what could I have done? And I said, well, the point is that somebody needed to know where that patient was, make the call and say, we're not renewing this. They need to go into a different facility or a different location of care that's more appropriate. if it in fact was more appropriate for the patient, and he said it was. She really didn't need to be there as long as she was. So it started good, he was real excited, and then he lost it all. So BPCI is retrospective, so all those claims get filed and then CMS looks at it compared to that budget. I told you it can be negative or positive. If a participant is a non-convener, then they're only responsible for themselves. But as a convener, you're responsible for everybody in that episode. That's part of the care. And then, then that's what I just said. Conveners do all the contracts. Episode initiators are typically acute care hospitals or physician group practices. The conveners will be responsible for getting the payment and apportioning out the money. They are also responsible for apportioning out the loss. So if you are part of a bundle and the convener sends you a check, it's a good day, but they could also send you an invoice because they're going to have to pay CMS back if you go over. So here's an example, because again, I like to do examples. It just makes it a little easier. In an episode initiator, so this is just one guy. One guy says, I'm going to do this. I'm going to play Russian roulette. He's got two conditions he's doing. So he's got clinical condition A, clinical condition B, and he's had 2 episodes. So 2 patients had this one, and 2 patients had this one. The target price for this one was $5,000. His actual charges were $4,900 for the first, $5,500 for the second. So he was good 100 for the first, but negative 100 for the second, which means he has got a negative end of episode, end of bundle total. Second clinical condition, he did much better. So target price was $10,000. He saved $2,000 on the first, lost $500 on the second, but as a net together, it was $1,100 that would have come to him in extra payment. If CMS applies we're keeping some of this qualifier in there. So when I put 0.95%, it's because CMS says that little bit is mine. We're going to keep that. That's how we're saving money. But the rest of it would go to the episode initiator as long as the episode initiator is doing this on their own. If the episode initiator is part of a convener situation, much more complicated, but it's the same idea. So in this convener world, you've got 3 of these episode initiators. They're each doing clinical conditions, and they each have net outcomes for each one of those conditions. In this scenario, there's $7,800 to be distributed at the end of this bundle for these particular providers. That $7,800, part of it will go to the convener, part of it will go to the providers. Here's the kicker. That convener can decide who can be in this bundle and who's not. The providers, the other initiators, can say, we don't want that guy. So if this guy who did really well, episode initiator 1, and this guy who did pretty well, say this guy's causing us a lot of trouble, then kick him out. And that $7,800 may have just gone up to about $9,400, and they would have made more money without him. So the performance of the people in your bundle or in your service episode is important. And that's a big part of this, and a big reason why in some cases we have not had a lot of people really want to join unless they know all of the pieces and parts that are along the way, all the service providers, because otherwise it's just too big of a question mark. Ultimately, the convener is probably at the highest risk because the convener is going out and trying to get the best quality cost providers, but they have really no control. So they're going to go out and they're just going to pray that those providers are going to do the exact same thing they've done before and have good outcomes and low cost. So who gets credit for the episode when there's all these people that could be in multiple bundles? Well, essentially, the first person who would get credit would be the attending physician. So the attending physician is the first person. If a claim never comes in with an attending physician or doesn't come in the time of the bundle, then it would go to the operating physician. And then if none of those happen, then it would go actually to the acute care hospital. So that's how the attribution goes, meaning savings for that patient or loss for that patient gets assigned in that order based on when they get the claims. But now we're seeing commercial bundles because BPCI is pretty risky. Nobody wants to jump in a pool and go, I am going to take responsibility for all care for everything that happens, even if someone has a heart attack, gets in a car wreck. I mean, all of those things could be included in that bundle depending on what the services are. Commercial bundles are popping up. Blue Cross, a lot of these are employer-driven. So an employer looks at their population of employees and says, God, we had a lot of people have hip replacements last year, and these are so expensive. Why don't we put a bid out to groups in our area and say, hey, do you guys want to do a bundled service for these? We'll send all our patients to you, and we'll pay you X amount of dollars, and we'll cut out a middleman altogether. Or we will go through a Blue Cross, but all they're going to do is basically distribute money. You send one claim, or you send multiple claims that go together, and there's no follow-up. You know how much money you're going to get. These typically limit what's in the bundle. So in these situations, they may say you're only responsible for 90 days for these specific services. So the risk is a lot lower. You don't have this, well, if they came in on accident from a fishing situation, maybe they broke an arm, maybe they fell out of a tree. Those things don't count because they wouldn't be part of this particular type of service and this particular type of bundle. These are prospective, meaning you're going to do the service, we're going to pay you an amount, and you just work that out. We hope that you don't give more services than what we paid you because we're not paying you anymore. It's typically for one procedure, and we're seeing DME and device manufacturers enter this space. Why in the world would a device manufacturer want to start a bundle? Because a device manufacturer can go out, try to save the provider's money, and also push their device. If you are a specialist and you were using certain things for joint replacement, if you're a device manufacturer and you were making some of those medical devices, medical supplies, then you can say, we're going to have a bundle. We're going to share savings and money with you. And we're going to help you save money. You're going to get a bonus, and you're going to use my brand of whatever it may be. So that's what we're seeing, and that is really interesting. I'm actually working with a group out of Tennessee who's working on this. So this is an example. I just told you this. Example would be like Happy Health System bids $30,000 for total care bundle because that employer says I'm spending too much money on knee replacements. So Happy Health System will contract with all these other people, orthopedic associates, radiology group, physician services, the rehab services guy, and then they go ahead and divide up the money. So Happy Health System says, we'll do it for $30,000. We're going to pay everybody. And the employer says, that's awesome because I was paying $35,000. You're going to save me $5,000 and everybody's going to get this money. And everybody just does what they need to do. If really cool orthopedic associate spends more than $9,000, then they're at a loss. But the payer doesn't care because all they've done is made one payment and it's up to the practice to manage it. Any questions about that? There are issues with these commercial bundles. And the big issue is one who triggers the episode. That is not always very clear in these arrangements. Our organization is actually processing some out of Washington State right now. And to coordinate the orthopedist, the rehab, the radiology, the hospitalist, it has been not easy because nobody knows when that episode started. They all disagree on what services are carved out. I don't want this service included in the bundle. I don't want this service. You should pay more for this. These are typically not all inclusive. We already talked about that. But we are also having some problems because you can't submit a bundled claim to a payer that has both pro fee, so physician services, like a $1,500, and a hospital claim with DRGs on the same form. They have to go in separate forms. And even if you could create some form, payers won't accept it. They won't take it. So payers typically can't make payments to multiple TINs. So you have to find another person to distribute that money for you, or it has to go to somebody in the bundle. So this is a big problem. Our issue when we're dealing with this practice out of, well, it's actually a whole group out of Washington, was Blue Cross up there was actually administering it. The problem is Blue Cross said, well, we want all the claims together. I said, well, you can't get all the claims together because it's hospital services and provider services. They said, okay, well, we need you to send them all at the same time. So, well, if I do that, then it may be a long time before things get paid, because even after the 90 days, some of those claims are still going to trickle in. And they said, okay. I said, well, the payment, you'll send the payment to us, right? Well, we'll send the payment to you if it comes in through you in that group of payments. If they accidentally send something, we'll make the payment to them. Then you'll have to reconcile that, repay them. So it has turned into a bit of a administrative nightmare. Remember when I said we're building this plane, is it flying? This plane is in the air, it is flying, and it doesn't have any wheels to land. One wing is kind of hanging off. So this is brand new. This is something you'll see a lot of. I think it has a lot of opportunity, but there are a lot of issues right now that haven't been worked out. There are lots and lots of employers, I know even in Birmingham, that have approached practices, approached other places hospitals saying, we want a bundle. Big payers, big employers in Birmingham have gone to the hospital and said, we want a bundle for this. And everybody said, that's okay. We're not going to do this quite yet. We're going to see what happens. It may be more popular in other areas, but here, this hasn't stuck yet. And I think it's probably because all these things haven't been worked out. All right. Now we have other plans, lots and lots of commercial incentive plans. Blue Cross Blue Shield of Alabama has a select plan, but they have lots of these in other states. If you are a primary care person and not in the select program, you are missing a lot of money. You have ability to get a 5% bump on all med-surg codes if you hit certain quality metrics, cost metrics. If you are a patient-centered medical home and hit certain satisfaction scores, you can get another 10% stacked on top of the 5%. And if you hit your quality metrics, which most do, then that's 15% on top. That's 30%. So the primary care doctors that are playing this game are getting 30% bump on their med-surg codes for all patients. That's insanity. And you would not believe how many providers are not participating in this. Or they're like, well, we really only do the quality section. Well, have you checked to see if the other sections might be worth it? Are you already doing it and just not reporting it? So there's lots of opportunity here, and these are all over. All the blues have various forms of this. This one has an opioid prescribing rate trigger. So in order to control opioids prescriptions in Alabama, because we are the highest prescriber, there is actually you actually are disqualified from this if you write too many prescriptions over a period of time for a certain length of time. So that's one of the qualifiers. And then there's also a qualifier for out-of-network labs. So if you send patients too often to out-of-network labs, you can also be disqualified for a quarter. This is looked at every quarter, and the percentage can change every quarter based on your performance from the previous. They also have the Advantage STARS program. This one's crazy. So for every Advantage patient, they have these care gaps that need to close. All the care gaps that they're looking at right now, these are them, have weights. The higher the weight, the more they're worth. The better they do in getting these care gaps closed. They can get up to, for this one, if you have over 85% care gaps closed, $75 per member per quarter. That's all members per quarter. $50 if you get between 80 and 85%, 84.9. If you have a 55 to 79%, you can be eligible for even other bonuses, but you won't get this incentive up here. All in, if you participate in all of this and get your gaps closed at 85%, that's $610 per member in 2019. $610. A lot of people aren't paying attention to this. One thing that I found very interesting is we do a lot of MIPS reporting. And the MIPS reporting, things like controlling high blood pressure. The reporting stats, the benchmarks for that are like 70%, 68% for controlling high blood pressure. When Blue Cross came and showed us their metrics, they were at like 22%. So these are the same doctors. How is it 68% for MIPS and 22% for here? And what we realized is they just weren't reporting it. They had done all that work. They had done all that work closing all those gaps. So many of these metrics overlap that you should be maximizing your performance, especially if your scores are high for quality or low for cost. Maximizing your performance in every program that's available. And finding and understanding the programs is the key. So my hope today is that you're actually going to at least go back and maybe say, can you check on this? Can you find out if there's one I'm not participating with? In Tennessee, they have the Healthcare Innovation Initiative. This is sort of a bundled payment, sort of MIPS kind of combination. They have a quarterback, which is kind of like our episode initiator. They have an amount of what's an acceptable level and what's a commendable level. If you hit commendable level, then you will get 50% of everything that is between what you spent and the commendable level. There is a maximum. The maximum benefit you can receive from that is $15,000. If you're saving $15,000 and that's only half of what you saved, then you were charging a whole lot for that joint replacement. But that's their program, so very similar. If you're seeing the pattern, the programs have all these different nuances, but the idea is the same. So the way you look at how you are actually managing practice and providing services really kind of shifts from traditional fee-for-service. Florida Blue, they're on the bandwagon. They got all kinds of stuff going on there. United Healthcare, same thing. So it's not, well, I don't see I always hear the pediatricians say, I don't see Medicare patients. I don't have to do this. I'm good. I'm like, okay, you're good. You don't have to worry about it. If you are not participating in any of this, you've lost nothing. If you are not participating in any of this, you have also gained nothing, and you may not be prepared for what's going to be required coming in the future. Right now, we got a lot of carrots. MIPS has got a stick. So if you don't participate and don't report up to the minimum, you're going to get a penalty. But a lot of these programs, it's all carrots. If you do it, we'll give you money. If you do it, we'll give you money. Blue Cross, we specifically asked Blue Cross of Alabama if they'd ever gone back to reconcile to see if closing the gaps actually made them, or at least broke even with what they paid out, and they said they never looked at it. They have no idea if that $610 that they're paying out actually gets them any more money from Medicare. Because those kinds of things actually do get them more money from Medicare. So that's why they offer it. That's what the incentive is. But they're not even looking at it. Eventually, I feel certain, eventually there will be a stick, and it won't just be a carrot. Cigna, Health Springs, same kind of thing. They have identified, and these are all going to be things you already know, high utilization of expensive services is driving up healthcare cost. Rising prescription drug cost is driving up healthcare cost. Overtreatment, particularly at end of life, is driving up healthcare cost. I know someone who has their 87-year-old dad, and he's not super healthy, but he actually may end up having a knee replacement. If he is able to use that and walk around and have a good quality of life, that's great. But do we need to be doing knee replacements on people who maybe can't and don't walk? I don't know. And I always say that. I'm always saying I'm a hypocrite when I say that, because if it was my husband or my dad, I'd be like, absolutely, give them whatever they need. So it's easier said than done. But that's the idea behind there. Providers practicing defensive medicine to avoid lawsuits. That is huge. We don't have any kind of rule on that. And so while we're preaching, don't do all these unnecessary tests, don't do all these things, at the same time, we're like, but we could sue you if something bad happens. So we have problems there that we need to address. There's fragmented, uncoordinated care, and there's all kinds of fraud and waste and abuse in the system. Most of you probably work with EHRs. They don't talk to each other, do they? It's a problem. So they want the EHRs to talk to each other to avoid the fragmented care, to avoid duplicative care, high utilization if you're doing things over and over, but nothing talks to each other. And even if it did, now we have HIPAA and security issues. So a lot of our outside regulations that weren't even part of this haven't caught up with what we need it to be to make this really successful. Lots of opportunity, but you just need to be aware of some of these things that are out on the periphery. All right, this is interesting. This is the Alabama Coordinated Healthcare Network. This is new to Alabama, and I'm also seeing this in other states. This is Medicaid. Medicaid's even getting in on the game on this. This is brand new here. Essentially, it's case managers. They're going to come in and manage a population. Providers who do Medicaid in Alabama will have the ability, based on their performance, to get a quality metric performance bonus, a cost effectiveness bonus, and if you're a patient sitter in medical home, you also get another bonus. They're already getting what's called a bump payment here for being a certain level of participant. So you get your bump payment, plus you get all these other payments. Here's the kicker to this one, because I had providers like, well, we don't see a lot of Medicaid. It's a lot of paperwork. For the first four quarters of the program, they're going to give every provider full bonus for quality and for cost and not even calculate it. Why would you not? Why would you not fill out the form? Fill out the form and participate. And if you don't want to participate, after they start calculating it, don't. But it's almost like it's a given. You don't even have to do anything for the first 4 quarters. And paperwork is a pain, so I don't want to underestimate that. But the idea is it's an opportunity, and I think a lot of providers hear it, they black out, and they don't even want to consider it. These were their quality measures, which are clearly more, child care visits, adolescent well care visits, much more targeted than your general HEDIS measures. All of this sounds complicated. So my little guy says, here we have the 30-day readmission flow that clearly shows the people, systems, and processes involved, and it's clear and patient-centric. Right? Because we've talked about a whole lot of stuff, and we've not talked about a patient one time, have we? All right. I always talk about this. It's like a tale of two cars. So you got car A and car B. They have the exact same everything. One car is $40,000 and one car is $36,000. Why are we not paying for care the same way? Why do we not select care the same way? One, we don't know. The data's not out there, but it is out there now. So you can't win any of this unless you have data to drive care. You need to know what your scores are. You need to know what other people's scores are. You need to know what their costs are. You need to know where they are in that benchmark and that budget. So data is coming in all kinds of ways. We are now seeing, this is an example, but this is real software that is saying these doctors, this is the cost for each one of those doctors for that service. Here's out of the Blue Cross site, which tells the doctor exactly how many gaps they've closed, where they are on the benchmark. This one's my favorite. This is real. This is here. And it's going to show every facility and based on the benchmark where they are. And I think that is readmission rates, skilled nursing utilization. I can't really see the other ones. But that's actual data on providers in your neighborhood. And I'm getting it here, which means you can get it anywhere in the country. So data at the provider level. And now your CBR, comparative billing reports, are out there. So if you want to see what people are billing, you can go out with a tax ID number to this handy dandy little thing and just look at where they are based on certain services. This poor guy, significantly higher than his specialty and significantly higher than the national average. If you're sending all your patients to that guy, then you may not want to be participating in one of the programs we just talked about. Patient level data, seeing lots of this. Very detailed data. Now even giving risk scores. Remember I talked about that budget? When you see a risk score in one of these softwares, do you know what that means? The risk score means that's how sick that patient is based on his diagnosis. A 2.5% risk score is about $2,500 added to your budget. So if you think about a point, about $1,000, if the risk score is 1 and you had a budget of $20,000, now you got a budget of $21,000. So this guy has a risk score of 2.5, which means that would be $22,500, roughly. All right, remember I said the data's now available? I looked at this 2 weeks ago. I was so excited because I'm kind of nerdy when it comes to this stuff. All of these places are giving data in detail. You can go to Hospital Compare on the Medicare website, look up a hospital. It will give you cost compared to other hospitals for any procedure, any major procedure, not little ones. It will give death and mortality rates. It will give infection rates. It will give readmission rates. It will give patient satisfaction rates. We have 2 hospitals in Birmingham that have 4 stars. The rest have 2. I don't know if it means you would change where you send your family, but it might. If you see high infection rates somewhere, it may change where you send your family. Same data is being put out on physicians, not as detailed because they don't have it and it's a little touchier. There's a lot more lobbying against putting out the individual provider data, but it's coming and it's coming out. So while you have access to it, so does everybody else. I talked about specialists, and I said the specialists say, I'm not going to do this, so why should I care? Well, you should care because all of your primary care doctors can get a list. This is an actual physician group comparison. This is an actual group here, and this is a comparison of their cost in different areas. Any primary care doctor can get that. So how do you get started? We already talked about this. Make sure you are participating in those incentives, especially the ones that have carrots and no sticks. The ones, if you got to fill out a form, find a guy to fill out the form. Call me, I'll fill out the form for you. Assess readiness. Are you really going to do this? So what are your current quality scores? If they're good, what are your options? If they're not good, are you really going to work on them? If you're going to work on them, what's the potential impact to your practice? So don't put in $1 million solution to get $1,000 of bonus, is essentially what that means. Make sure your partners are ready. If all the people you send your patients to are tanking, that's probably not a good time to join any of these programs. Clinical workflows, staffing. This takes staffing that are actually going to buy in because they're going to have to help manage some of these processes. And then financial and operational readiness. If you're going to go all in with a risk model, are you also prepared to pay? Because everyone goes in hearing, ooh, I'm going to get lots of money. Well, there's usually 2. There's the people who say I'm going to get lots of money and the people who say I'm going to lose my shirt, and there's like nobody in the middle. Small independent practices are doing better than larger groups. And always be honest, because not everyone saves $1 million. Providers have to engage even if they don't do all the paperwork. So no matter where the destination is, there's always a way to get there. So the destination is nowhere, there's a road. Anywhere there's a midnight train. There's also a midnight train to Georgia. There's a last train to Clarksville, a stairway to heaven, a highway to hell, which I find interesting. Apparently there's more traffic going to hell. And then Dark Desert Highway to get to the Hotel California.